By request of the meeting organizer, this meeting is being recorded.
My name is Michael Hager, the Manager of Technical Assistance and Dissemination at the National Quality Center, and I'm happy to welcome you to our April 21st office hours for the End Disparities Learning Exchange. Today we'll be talking about behavioral versus perinatal infected youth and the important differences between the two. Before we start, one of the ways that we get to know each other a little bit is to write our name and a little bit about where we're calling from in the chat room. I see that we have about 25 people on the line right now, so I'm going to leave the lines open, but I will mute all lines if we have too many unwanted distractions. You'll see that I've been muting lines as I go as well. So I'll start that out. Michael Hager, NQC, NY, and Disparities Leader. Okay, and I was just told by my colleagues who are leading another call that I need to be a little quieter, so sorry about that. Great. And I see people.
Michael, when they enter their stuff in the chat room, it automatically goes just to you. I think the everyone is a step above, so they may want to look for that.
That's a great point. Thank you so much for that, Jane. So in the chat box, you might see the send to, and yeah, just click that button as Jane mentioned. Thank you so much for that.
This chat, get a bubble.
Great. So, and that's right, if you do not yet see the chat room listed, what you need to do is where you see my face, there's a little gray bubble above it that says chat. If you click it, it'll open the module below my face. For those of you who are joining us for the first time, welcome, or listening for the first time. Just to give you some background, the End Disparities Learning Exchange is a 9-month initiative that promotes application of improvement interventions to reduce HIV disparities for specific populations. We selected 4 populations as examples based on national priorities, but of course we know that disparities can exist anywhere in the groups that we serve and can be defined in a number of ways. And so really what we're trying to do is to help everyone identify how they can apply discussions and learning around disparities to the populations they serve specifically. We're doing this while bringing you all together from around our gigantic, diverse country so that we can all learn from each other as a community of learning. So just a quick plug for our End Disparities Learning Exchange video. If you've not seen it yet, it's a great way to summarize what it is that we're doing here through this initiative and to, energize people within your community, whether they're providers, community stakeholders like consumers or other groups that you might work with. It's a great way to energize them and to encourage them to listen in and to weigh in on this important topic as well. So office hours are they are on Friday. They're not every Friday. They're always at 1 p.m. though. We invite you to go to our website, enddisparities.exchange.org, or check our newsletter to find when we have upcoming office hours. There's no registration. It's open to all. And the neat thing about this is that we're not talking about this. We're not talking about this as experts per se, but all as equal stakeholders in learning and growing together. Our call is facilitated by folks who have been doing this work for a number of years and are very experienced in it. But of course, you're equal partners in this discussion, and so we want to raise your feelings and your thoughts and your observations, in this discussion. And I'll be in the background taking some notes on the whiteboard. And again, today's topic is behavioral versus perinatal infected youth. So at this point, I'd like to turn it over to my friend and colleague, Jane Caruso. Jane has been working with the National Quality Center for about 7 years now. Before that, and even a little bit overlapping with her time with us, she was the Part D program lead for the state of New Jersey, which is a network of sites. And so she has a great deal of experience working with youth and in thinking about this specific question and other questions related to working with youth. So at this time, I'm happy to turn it over to Jane to introduce our other speakers and to get the conversation going. Jane?
Sure. Thanks, Michael. So as Michael said, I was a Part D program director for a long time and worked with a lot of youth, both perinatally and behaviorally infected. I'd also like to introduce Julia, who is our other facilitator this afternoon, and she's from Duke University and also has a lot of experience with working with this population. Julia, do you want to say anything specific about yourself to us? Just so we know kind of who's on the phone and who's facilitating and who you are. And it's okay if you don't, or maybe you're muted, and that's fine. What we're going to do today is talk about the differences between these two populations. And we sometimes like to subpopulate the subpopulations because, you know, youth is already a subpopulation. And sometimes when we dive a little deeper, we can come up with interventions that are more specific to a special group. Like, for an example, we might look at youth, and then we might look beyond that to another subpopulation, which might be young MSM, and we might go beyond that and look at young MSM of color. So as we start to reach where many of us are, getting to that 85 or 90% of viral load suppression, the hard-to-reach populations often need a more targeted, focused intervention to pull them in. So what we want to talk today is any differences between the two youth populations, behavior and perinatal, and see if there really are differences. Some say there's a lot of similarities too, and I'll just get us started by talking about some points from yesterday's conversation. It wasn't our intent yesterday to talk about the differences between these two groups, but they came up, so I'll just share them with you to get us started and to get you thinking. We talked about medication fatigue in the perinatal. We talked about cognitive impairment in the perinatal. We talked about stigma and how it affects each one of those populations. We talked about provider bias. We talked about missed opportunities in reducing vertical transmission. We talked about differences in parental support between those two groups. We talked about how disclosure is different. We talked about how transition is different. We talked about whether or not we can keep these two populations in the same focus groups. So just to get us started and thinking about these things, I want to remind you that it's not my job to teach you or train you today. It's my job to generate discussion and hear from you any challenges you have with these populations, any differences that you think are significant that might impact the way we care for these groups. And so if you have a suggestion, if you have a success story you want to share, if you have a challenge you want to share, we're all open to hearing that today, and we would all love to comment and chime in. So is there anyone out there that would like to get us started talking about something particular in their own clinic or their own experience that delineates this difference between these two groups? And this is not a time to be shy, okay?
So this is Rachel Disney talking from Duke Hospital. What I have noticed also, not just medication fatigue, but also coming to the doctor fatigue. The kids that are we're seeing that are 16, 17-year-old new diagnoses, they connect very closely to the clinic pretty early on and want to learn. They want to get more education on HIV, but also about disclosure. They're really invested in their health, where I see sometimes some of my perinatally infected or youth are tired. They don't want to talk about HIV anymore. They don't want to talk about medication, and I just want that to be one of the things that is talked about today.
Yeah, sure, and I'd love to hear from other people. Do we think that in that perinatal group that the medication and the disease is kind of just their normal life, and maybe they don't pay as much attention to it as they should because they've normalized that? Any other thoughts out there on either medication fatigue or office visit fatigue?
So this is Dolores out of New Jersey, and I think that it's not a difference, it just might be the topics that are different. So when it comes to mental health issue, a lot of perinatal infected individuals are very concerned with anger and just it's probably anger against parents or just anger about being perinatally infected. And so I think the mental health issues might vary depending when you look at the difference between the two groups.
Sure, that's very possible. I did hear yesterday that the depression seems to be deeper in the behavior because really I don't know why, possibly because they brought this on, or it's just a whole new, it just turns their life around upside down all of a sudden, whereas in the perinatals, they're born with it and they deal with it every day of their life. They have, since they were toddlers and could speak and go to school, they've dealt with this. And someone who's 16 or 18 or 20, I mean, it's your whole world is turned around.
Yeah.
Anybody else can address the fatigues issues with the office visits or the medication? Has anyone had to address this or think they need to address this?
This is Julia, and one of the things that I thought that was very interesting, Rachel and I were talking the other day, and when we were talking about it, she mentioned that, you know, kind of to expand on what she talked about, when a new patient comes in who's behaviorally infected, it's kind of like, wow, this is something really important because look at all of these people who are involved in my care. Look, I have my own case manager. Look, I've got my own provider. They're all asking me, and there's just this level of attention on them, which is very new to them versus for a behaviorally infected kid or youth who's all of their life have seen these people, and all of these people, there's not that same kind of, oh, look at all of these people. It's more like, oh, look at all of these people. It's a very different way of kind of looking at the number of people who are involved in your care.
Is that someone else speaking up? I couldn't hear. Okay. Anybody else experiencing that issue? Is anybody else trying to deal with that, trying to make the perinatals a little bit more attentive, or do they think it's just not something that's as critical? Any other thoughts on that? Okay. So Julio, do you work with those perinatals in any way to try to bring them back around to where maybe you want them to be?
Yeah, so we're a Ryan White Part D funded site, and we have in our clinic, we see the majority of our patients are perinatally infected. We do see a few behaviorally infected in one of our other subrecipient sites. They're predominantly behaviorally infected. And then in our Duke Adult Clinic, we have a few behaviorally infected youth over there that they see, as well as the women that they see. And you know, for each youth, it's different. I think that we have to be very careful in whenever we're kind of trying to say what are differences and similarities. For each youth, it's different, and there's many different factors that kind of go in with that. We saw a very interesting poster the other day at this research, at a research event that they had here at Duke, and it talked about a study that was done in youth who were perinatally infected, and how they were disclosed to, and whether they were disclosed to by someone or whether they found out by themselves, and kind of what that did to their mental health as a result. And I think that we have to also kind of look at those factors for each one of our kids as well, and say, what is the history with them? What are their living situations? Do they have their biological parent at all anymore? The majority of our our perinatally infected youth are orphans, and are, you know, have been adopted either by maternal grandmother or aunt, or by someone else. And so all of that factors in. It really kind of factors into the whole mental health of that child.
Absolutely, absolutely. And we did hit on that a lot yesterday about disclosure and whether there's a right time to do it and how it affects mental health and how it affects stigma. And with the young ones, with the perinatals, there's a school of thought that they need to know right away, and by the time they're school age, they understand they have a virus and they have to take medicine. And there are others, parents that I know, that have not told their children till they were in their teens, 15 or 16, because they wanted to keep them from being stigmatized and they wanted them to have a quote-unquote normal life and all that stuff. So I'm just wondering if anybody else has thoughts on disclosure. With the behavior, it's there. They take a test and it's in their face. They have it. But with the perinatal, it's a little different. I mean, it can be a gradual normalizing thing. It could be something that waits till later. Does anybody have any thoughts on that, or do they have a goal or a policy in their clinic about when that occurs for the perinatals?
Sure. This is Erica Hayes at St. Louis Children's, Washington University. So for our kiddos, I mean, our goal usually for disclosure is somewhere around the age of 10 to 12. And, I mean, not every child is going to be ready at that age. If there's developmental delay, we have a fair number of international adoptees, and if they're adopted at 9 or 10 and they don't even speak the language very well, I think it's very hard to have a comprehensive and sensitive disclosure discussion with them when they don't speak the language, or to even do that through a translator. And then we have some kids who are very advanced who may actually be ready for disclosure later. Our goal is that everyone in our clinic, though, is disclosed by 13 years of age because, certainly at that age, the likelihood they may become sexually active is higher, and they need to know their status so they can disclose to the partner.
Exactly. That's exactly the problem that we encounter when parents want to wait. So who does that disclosure? Do you have a specific way, or do the parents do it? Does the provider do it? Do they do it together, or is it different for each?
So we have a couple of different approaches, and Kelly and everybody else on the line from our program also chime in. But, I mean, so we really offer, different options. So for some parents, they're very, comfortable doing the disclosures and the discussions at home. We're obviously talking earlier on about you take medicines to stay healthy, but we're just not saying the label of HIV necessarily because, again, very young children, 8-year-olds, might not understand kind of what's private to keep between me and my family, and telling the public where, unfortunately, we've had some serious ostracism and issues happen for some of our children in schools and other places when they disclosed. And so some parents are comfortable doing that, and then when they come in at their next clinic visit, we discuss that. We can give materials. Phyllis Ballard, our nurse, helps them with that process, kind of finding and identifying good materials at the age level for the child. Some parents are really not comfortable doing it at all, and so they want to, have us present to do that process with them, and we're happy to do that as well. We have had parents who didn't even want to be in the room when we disclosed, and so had them come in and work with a team with our social worker, our nurse Phyllis, usually one of the physicians, myself, and other people, the caseworker, case manager as well, to kind of go through the process.
Awesome. Awesome. Anybody else do anything different or have more to add on disclosure?
I have, I'm Susan O'Hara. I'm from Nashville, and I work with transitioning, so I'm mostly working with adults, but we also work with our pediatric clinic at Vanderbilt for, so I see some of the perinatally infected kids, and there was a period, I guess, where they weren't, the disclosure wasn't happening until really late. And so for those folks, there's so much anger and frustration and hurt, and just like we really see the need for it to happen earlier, and I think, yeah, before 13, because, I mean, we have students who were becoming sexually active and didn't know it. They weren't necessarily revealing that to their pediatric doctors, but, so, and then finding out so late, just felt like, you know, this information being withheld was really damaging to their trust and their sense of self and all that kind of stuff. So,
really interesting. Yes.
This is Julia. I want to kind of add to that as well. We have youth who, if you wait too long, our youth are very technologically savvy, and they look up their medications, they look up what the pill looks like, and they find out what the pill is for. And so it's a way that they're being self-disclosed to because of their curiosity about what's going on. And I think that's again, this whole issue of the anger and the hurt that they weren't told.
And I think just to add on to that as well, I think there's also this idea by us not discussing it with it, and we've had some kids say this to us here, that they thought it was something worse than it was because no one was talking about it as well, I think is a factor to consider. Because often the kids know something's up, they may not know what it is, but the fact that no one's talking about it can often be even scarier than actually just telling them the diagnosis.
This is Dolores. I was just wondering from the experts if in delaying telling, helping them to disclose, whether parents or provider disclose to them and them having to disclose, isn't there an element that is introduced of stigma? Because I think when there is so much secret around it, it makes it more stigmatizing. And I wonder if when dealing with this population, if that's something that is relevant. Is that something you encounter?
I mean, it can be. I think it's important when I'm using language and talking to parents who are getting ready kind of to do the disclosure or start the discussions with a young child. I think it's really important to stress that it's private, it's not secret, because I think secret implies something needs to be hidden, there's something shameful about that, whereas talking about being private and keeping it between the family and talking to people who know the status, and again, stressing that the child has done nothing wrong, there's nothing to be ashamed about, but that unfortunately, some people don't understand it and react in a negative way, and that's the reason we keep it private, but that it's not a secret because it's not something they need to hide or be ashamed of.
That's an interesting difference. Thank you for that. Very interesting. We do have a comment in the chat room from Sarah. It says, our policy is to disclose at 13, and one of the biggest challenges is getting parents comfortable with discussing this with their children, especially if younger siblings are HIV negative. We kind of touched on this, but does anybody have any advice or suggestions here, getting parents comfortable talking to their children, especially when the younger ones are negative? I wonder if that causes resentment within the family. Okay, no help out there on this one, huh?
Nope.
Okay, so there's another question which is interesting, which I've encountered, and I think maybe some of you have. I'm wondering if other clinics have had parents withhold consent to disclose and how that was handled. And I did say we did have one teenager who we knew was becoming sexually active and the parent was not going to tell and didn't want the provider to tell. So at that point, when it becomes critical for the child to know, does the provider just take the bull by the horns, or what happens there?
I mean, I think one approach for that is important, is really to start the discussions even about when we're going to disclose the status, even before the child is ready. So at 6 or 7, we start, sending the kids off to play with someone in the clinic and asking the parents privately, what have you guys started talking about? What are you thinking about? How are you going to think about doing this process? How are you going to do it? How are you feeling about the process? And every time we see them, or at least every other time we see them, because we see the little ones fairly frequently, we check in to kind of see where they are in the process. Are they starting to share the information? And by having those conversations, a lot of them start having the conversation and talking with the child on their own, not always, but I think that's important because they see it coming. And then usually around 9 or 10, I start saying, I think it's getting around time. What are your reservations at this point? And then, you know, we keep saying, and then I say, you know, really our goal is that this needs to be done by the time the child is 12 to 13 years of age. So if we've gotten to 12 to 13 years of age, hopefully it's been on their radar for years. And, you know, if we haven't done it yet, then we say, you know, we've been talking about this. This needs to happen now. How can we do it in a way that's going to make you feel most comfortable? Because I think one of the biggest issues we have is disclosing their status discloses mom's status to them, and it's something that they haven't discussed. I don't know, Phyllis, do you want to talk about what happened with the support group when you were talking to them about how HIV was transmitted for our perinatal youth?
Can everyone hear me?
Yes, thank you.
So one of the things in talking with the kids, we were doing HIV 101, and the kids all knew they were positive, but the parents had not shared with them how they became positive. So they started asking me, you know, I see how you get it, how you transmit it and whatever, but how did we get it? So in talking with the parents, a lot of them were not comfortable with sharing their diagnosis because, disclosing how the child got it, because that meant that they would have to disclose their own diagnosis. So I think one of the things we could probably do is try to suggest having them have a session with a mental health specialist to kind of go through those fears and what things they are worried about or scared about in disclosing their diagnosis. We have done that once with a mental health specialist in the room, and it was interesting that the mother biggest fear was that the kids were going to blame her for it, and actually it turned out to be a really positive reaction session.
Okay, thanks. Thank you.
This is Kelly, also from St. Louis. We also had a situation where kind of what you were referring to, where the parent did not want to disclose to the child, and we have a non-disclosure camp, so we don't talk about HIV at the camp, but the kids, one of the other kids asked her who in her family had HIV because someone had to have HIV to be there. And she had seen the paperwork, had her name on some of the paperwork. So she came up and asked myself and Phyllis if she had HIV. So I ran and called the mom who wasn't there with her. The mom refused to let us disclose to her. And then from that point forward, actually continued to not disclose to her. And this child was, Phyllis, like 14?
Yes, at the time.
So that child held on to that anger, didn't take her medication, and subsequently died. So I think that is a big thing. I mean, even when she was sort of had some evidence there, and then there was probably this mistrust of us. So that was always my question: at what point can we tell the child without the parental consent? I don't know if anyone has any.
Yeah, this is Therese Orville at UCSF Benioff Children's Hospital, Oakland. One of the things to avoid that kind of situation, to let parents know very early that if the child asks, we will not lie, and that we hope that the parents will be on board with us. But in order to maintain our relationship with the child, who is our patient, I think it's really important to let parents know early on that if the child asks directly, we won't lie. We'll ask, do you understand? What do you know? We'll try and bring the family in to also be part of that discussion. But that's one of the ways that you can potentially get around that issue.
I like that.
Thank you.
Well, this is Tara at the Brooklyn Hospital. It's important to note that the law usually only protects medical providers in making that choice, and social service providers like myself are not actually allowed to have that kind of flexibility without parental consent.
Okay, so there is a difference then between the providers being a medical provider and being maybe a medical case manager, or what about a nurse?
In many states.
Okay.
Yeah, you'd want to talk to the legal department if you're at a hospital, or look into the laws in your state.
Yeah, I agree that those laws need to be evaluated, but I think that specifically relates to the physical and the actual act of disclosing, not answering a question.
Okay. Okay.
One of the things,
sorry, I just want to add that we're kind of keep talking about disclosure, but it's the term HIV. We have some people who HIV is not going to mean anything to them, and so it's really, you know, what's going on in your body, and that you can pass it on to someone else, and really understanding those things, because HIV itself is just a term, and that doesn't mean anything.
Okay. This is Susan. I was going to say that I think it's an important part of the conversation to talk to the, parents that the withholding of the information, I mean, whether it's having a secret is usually damaging to relationship, whether it's something that they're withholding about HIV or whether their status, and sometimes to me it makes it seem even more stigmatizing if, working through the parent stigma, you know, internalized shame and stigma about it, but that kind of seeing that their fears of disclosure is really adding more power to the kind of the transmitted stigma. But I really come down on the side of, you know, more information is better all the time, usually.
I have to agree with you, because that's my concern about, you know, we work to decrease stigma, but there are just so many factors, and some of these situations contribute to continued stigma around HIV.
So do we find any difference in stigma, Dolores, do you think, between these two groups? Do you think one is any more or less stigmatized than the other, the way they feel about stigma, do you think, or is it just a universal thing and they all are?
I think they would experience it to some degree differently. First, there's the stigma around this, whether you keep the issue private or it's a secret, and that creates that environment of there is something wrong with me, I am not normal, I am not like anybody else, and there is something wrong with me, and what is wrong with me could be interpreted as bad. And then there is the stigma that they'll experience in the general environment. So they, in their private setting, they might internalize some of these stigma messages that they get, but they also have to deal with the external among their peers, or as they decide to get involved in sexual relationship and then need to disclose at that point. So I have to agree with you that I've said that disclosure needs to happen earlier, because disclosure is one thing to know your own status, but then is to have the confidence to be able to tell somebody else and to feel confident in yourself that there is nothing wrong with you. And so as providers, we have to work through these issues and help young people just to help them to live normal life. I was so sad a while ago when you said that young person died, you know, because it kind of underlines some of this discussion that we're having around stigma.
Okay. So we have one question in the chat room. Any suggestions how to address an immigrant family, parents don't speak any English, to a perinatal child 11 years old, mother has not and does not want to disclose to the child? Any suggestions? We may have kind of covered this already, but any other specific suggestions on how to assist this parent making them willing to talk to their child? I think we probably kind of already spoke a lot about telling them early in the trust and how much more difficult it is and dangerous it is to wait till later. So any other comments on that field?
This is Julia. I just want to say that, you know, while it is something that you do want to start addressing, it's also you need to be very cognizant of for certain immigrants from certain cultures who the only interpreter may be someone from their community and known to them already. And this we ran into with some of our Middle Eastern patients that we had recently, that there were very few interpreters, and those interpreters were people who were kind of socially known to them. And so there's additional issues there as well, and you need to kind of be very cognizant of those and point those out, that this person is a professional, that they will not share that in the community. There's additional levels of trust that you need to build up.
Mm-hmm. Okay, thank you. Thank you. Let me just see what else is in here. Okay, so any other thoughts on disclosure or any other topics that anybody specifically wants to make sure we address today?
I wanted to, sorry.
One of the issues that comes up with many parents is the emotional charge around the diagnosis of HIV and AIDS because of the historical and them living through the major part of the epidemic. I think that charge is not there for most kids. They don't have the same connotation when they hear HIV and AIDS. And I think parents can be counseled around that kind of emotional charge for them that may not be there for their child. And considering that, again, depending on an immigrant family or an internationally adopted child who may have that emotional charge because they've lived through seeing people in their own country die of this disease when medications are not available.
Interesting. Okay, thank you for that. Okay,
I was going to say something, sorry, this is Susan. I was going to say something back from the beginning about the depression. And in my experience, my perinatally infected clients seem to have more like of the numb, more looking like PTSD, and definitely depression. And with the behaviorally infected folks, I mean, and this is just, you know, anecdotally, but the behaviorally infected folks, there's depression and frustration and sometimes, you know, just anger at themselves and or feeling in some way betrayed, or all that stuff, but it doesn't quite seem as, it's more buoyant, you know, they can bounce back in a way, like after the processing the new diagnosis, whereas the perinatally infected folks just seem like their baseline is so much lower. And maybe that's just because that's who I'm seeing. I'm already, I'm not seeing every single perinatally infected person, but it's just the heaviness and the, you know, the trauma, a lot of the, you know, whether it's from the trauma from the hospitals and doctors and loss from parents or other family members, so.
Yeah. Susan, this is Erica from St. Louis. I completely agree that we see the same thing in our vertically infected, perinatally infected patients, that definite. And I think it's even more than I'm just burned out of taking medicines. I think you hit the nail on the head, as well as, I mean, I think we underappreciate the trauma of just living with HIV on these kids. You know, we have one of our patients who always says, you know, she doesn't take her meds because every time she looks at that pill bottle, it reminds her she has HIV. And emotionally, it crushes her on a daily basis.
Okay, and any other comments in this direction? Is there
This is Julia. I just want to add to that. I think that, that I totally agree with that as well, and I think that one of the things that is so challenging is that so many of our perinatally infected kids are not accepting of mental health care. So we can try to get them in with someone, but and get them someone in their local community and go through this over and over again, but have very little success.
Also, the state of North Carolina's mental health has declined over the few years that we've been trying to get them into practices, and there might be one practitioner in their 30-mile radius. So it's not only that they have a difficulty going to appointments, access in the state is also difficult for them.
Okay, another interesting point about stigma up on the chat room is about the parents feeling the stigma for their kids and the youth, the young people, learning about HIV in school and very possibly seeing HIV in a different light than their parents are. It's a different era, a different generation, and this new generation may actually understand that this is just a chronic, I don't want to say just a chronic infection, but their parents never had that same education, and so their view of it is different. So I just thought that was a very interesting point that's posted up there. I don't know if everybody can see the chat. Anybody else in this direction? There's lots more that we can talk about regarding these differences. Does anybody have, before I just throw one out there, does anybody have anything that they really want to discuss today that we haven't touched on yet? Okay, so.
you know, Jane.
Go ahead, Dolores.
You know, yeah, the only thing that I don't think that we've talked about a lot is the economic access for children who are perinatally impacted and those who are behavioral. And I don't know if that's a difference, but, you know, as these young people get older, economic access is an issue of housing is an issue, and I just don't know if there are any differences there or it's just the same. They're the same population of youth just needing to find their ways when it comes to these resources.
Yeah, resources are tough. We did talk about that a little bit yesterday, housing and jobs and schools and the parental support that either gives or denies those resources to the kids. We had one child who was infected, I guess, at maybe 16 or 17 and was afraid to tell his parents, and so he began to use his parents' health insurance thinking they would never find out, and they did. So that the parental support is really important. I mean, I think if you have a perinatally infected child who still has their parents, that there might be more support there, but not necessarily true either. Any thoughts on that, parental support differences or?
I think when we're talking about perinatally infected kids, we're really talking, as we said earlier, about subpopulations. So there's certainly a subpopulation of kids coming up who are internationally adopted who are going to be in very, very different socioeconomic situation than perinatally acquired kids that we saw 10 years ago. And I think
very good point.
It plays into what we're going to be seeing in the future. And in fact, 40% of our population right now are kids who are internationally adopted.
Wow. Okay. Anything else? Any other burning topic we want to address? Has anybody done? Go ahead.
Sorry?
Go ahead. You can go.
So I was going to say, you know, in our clinic, we have been, you know, kind of looking at our clinic, and we're actually working on a quality improvement project related to this. But, you know, when we look at our clinic population and we look at really who's not virologically suppressed, the group that sticks out like a sore thumb is 19 to 24-year-olds perinatally infected, particularly females. And so we're struggling to try and, kind of figure out how do we solve, and I mean, again, it's not a lot, I think it's 5, puzzling to figure out, how do we kind of help them, because most of them are kiddos who've had, unfortunately established non-adherence to their antiretroviral therapy now for some time. But it's really very consistently this perinatal group where we, including some boys as well, but more so females, where we have really the bulk of our lack of virologic suppression. I don't know if others are seeing that.
Is that a common thread? Does anybody else have that concern as well?
This is Rachel Disney. So we are seeing the same thing in our 19 to 24-year-olds, 25-year-olds, but I'm not seeing a gender difference. It's pretty even between the genders for us here.
Mm-hmm.
Is this lack of suppression due to just deciding not to take their medication, or are they resistant? Yeah, okay.
Yeah, that's what we're seeing as well.
They're on regimens that should be active. We've had multiple genotypes to make sure they haven't acquired new resistance, and no, they're not taking. And we have a few of them who tell us they're not taking them at all.
Okay.
And I think that particular group of youth is at highest risk when it comes to transmission because they're transmitting highly resistant virus. Many of these kids have had 8, 10, 12 different regimens, and they have highly resistant virus. And unfortunately, many of them choose not to take their medications until the point where they have an opportunistic infection.
And some of them don't even choose it then. I have a few girls who I've admitted with pneumocystis. I have one currently in-house with disseminated histoplasmosis, still hasn't gotten them around to taking their meds despite life-threatening opportunistic infections.
Found that the female youth who become pregnant are much more likely to take their medications during pregnancy, but not to continue their medications afterwards.
Yeah, no, we have a case there that would also be the exception to that rule as well. One of our perinatal youth who got pregnant at 22, and she did not take her medicines during her pregnancy, and the baby's 14 days old, and we're waiting to see.
Boy.
Yeah. And she's also, again, this kind of perinatal, same age group.
So has anyone done any quality improvement work on missed opportunities regarding vertical transmission? I know we do a good job in this country when we have them in our clause, maybe except for that one, but we generally are pretty effective at getting moms to take their meds and have babies that are healthy. But the ones that slip through the cracks, the ones that the hard to reach ones are the ones that we really don't know about. They're the ones that don't get prenatal care. They might not know they're pregnant. They might know they're pregnant, but they don't know they're HIV infected, and they're not in prenatal care. So, and those are the ones that slip through the cracks that we still have maybe a positive birth every once in a while. Has anybody done any work around that, trying to reach the unreachables?
This is Julia from Duke, and some years back, I mean, this dates in 2008 already, we started a multidisciplinary team meeting that we meet once a month, and we have 2 outreach workers who pretty much find out about any HIV-positive pregnant woman around, and they check to see where they're receiving their care and that they're getting care. We communicate with other hospitals in between. The team meets once a month. We have OBGYN at the meeting. We have clinicians from both the adult and pediatric clinic at the meeting, and we have social workers from all 3 of the different clinics at the meeting as well. And it really is a way that we can make sure that the woman is in care somewhere. We can track viral loads as she is going through her gestation. And then once she does deliver, before she delivers, we can make determinations of what is the best medication to give the exposed newborn and how long, and whether the exposed newborn needs to be on additional a 3-drug regimen or Bactrim. And then we'll follow the exposed newborns as well through their graduation. During that period, we also make sure that the mom has gone back into their regular HIV care and after they've given birth. And it's been very successful. There's always a couple that are very difficult to track, but it's something that's been going on for a long period of time, and I feel like we've had great success in really tracking people who otherwise would be lost out there. We had, I know a couple of years ago, we had someone who was completely convinced that she was not infected and refused to take medications and go to any visits. And they, you know, Rachel could probably speak a little bit more about some of the things they had to do in order to make sure she got into care.
We definitely had people going out to her home and getting her engaged and understanding what was going on, and that was a success story. I mean, we were able to get her to understand that she had to get care in order for her child to remain negative. And it took us a lot of effort, but she finally went to appointments. But it was a lot of education.
Okay. Anyone else?
There are also a few centers that are doing admitting women towards the end of their pregnancy for directly observed therapy when they're not fully suppressed. That's obviously if you know that that woman is infected and is out there. We also, not just looking at an infected child as a sentinel case, but any woman that's identified at delivery, we kind of investigate in the same way as a sentinel event to look at what were the missed opportunities in her access to care, whether it was methadone clinic or accessing care through a community agency or being seen at 3 different emergency rooms, and really looking at what were the missed opportunities.
Okay. Anyone else? We have about 10 minutes left. I can throw a couple topics out there unless someone else has some, because there's other things that we could talk about as well. Focus groups for youth. Are you able to bring perinatal and behavior together in the same focus group, or is that not a good idea? Have you had them separated? Another topic would be bringing youth to the QI table as part of your committee. Has anyone engaged youth actually on their committee in a quality improvement project? We could go that way. We could talk about transitioning. Is there a difference in the way you transition your perinatals to an adult clinic, to adult care, to adulthood in general? Any of those topics hit a chord with anyone?
Hello.
Hi.
Yes, this is Fallon from St. Louis with WashU, and we actually, some years ago, 2 of the previous case managers had a perinatal support group. It was really successful. The kids really enjoyed it. And they also were able to, like, allow their partners to come or either their siblings to come. And due to some scheduling situations, it ended, but we resumed it last year. And one of the key points that a lot of the participants said that they only wanted perinatally infected participants this time because they felt like they had, you know, a unique situation that behaviorally infected may not be able to understand. So we have kept that core group of about 4 to 5 individuals who come every month, and they're able, it's a safe space where they can vent and talk. But we also have a community liaison person from one of the pharmaceutical companies who's actually a former Ryan White case manager who provides speakers who come in, and we provide food, and we also assist with transportation. And we really have a good core group who come consistently each month, and we found that to be successful.
Yes, and I've heard that before, and that was my experience also, that I couldn't mix the 2 in the same group because neither, and not only did the perinatal feel they had, you know, their own special circumstances, so did the behaviorally infected. So any other thoughts on that, on trying to get those to work together? Or did you need to separate, or maybe you don't do focus groups for young'uns? Okay. Has anybody else encountered provider bias? I had one instance where a higher-up person informed me that we had to really take good care of the perinatally infected because they were innocent and didn't do anything wrong, but the behaviorally infected, well, they had a decision to make, and they made a bad choice. And that kind of made my heart go into my stomach. I thought, you really don't need to be working in this field. But has anybody else encountered any kind of bias in their providers? And maybe not just medical, but it might be dental or any other.
We've had patients who have had dental care refused to them, and they've had to, drive a couple hours, rather than being able to go to the dentist in their hometown, having to drive 2 hours back to us to go to their dental appointments because their local dentist would not see them. One of them particularly heartbreaking. So they ended up actually changing the whole family's dentistry care because their child with HIV asked, why can all my brothers and sisters go to see the dentist who everybody loves and very pediatric friendly, and I can't go?
Oh, boy. Yes, that is heartbreaking. That is sad. Any other stories? Any other bias stories within the providers? I think that once these programs are established, that bias goes away because we bring the right people in. But sometimes when you refer out, you still get that. You still get that bias. Has anybody used their youth in a quality improvement project? Has anyone had a young person sit on their quality committee and help with some kind of project? Whether it be behaviorally infected or perinatally infected.
We have not, but we need to.
Okay. We had one sit on a committee looking for these women that were pregnant and not in care, and she was a young one too, going through the same process. And she informed us, she says, well, I know where they are. We all know where they are. It's just, they don't want to squeal or rat, but she said, we know where they are. We're consumers, we know where they are. I can find them. And so she brought one in, and I asked her, where'd you find her? And she said, on the corner of Broad and Hudson. I said, okay, as long as you found her, I'm happy. So sometimes youth have a special quality that is really beneficial to your committee, especially if you're working on a project for youth. You really want to try to reach out to them, and possibly the behaviorally infected might be more impactful on your group. So I don't know if you had any thoughts on that, but if you haven't really tried to use that avenue yet, then maybe not. Let me just check the room here.
This is Julia. I just want to kind of add to that. We've tried to engage youth a lot in our consumer boards over the years, and we can get someone to come maybe for one visit, but it is very difficult because a youth's calendar is very different than someone who is older, and getting them to think about coming to a meeting on a certain date and continuing to come to that meeting, a lot of it is based on what's happening at the time. And so we found it challenging to have people come consistently to meetings, and one of the things that we tried to offer was even having a smaller group of youth who then could take turns coming, so that it wasn't one that felt like they had to come all the time. But it's been a very challenging population for us to work with.
Yes, and I hear that a lot, so I'm sure that's common. I'm going to jump to one last question before we close. It's in the chat room, and maybe someone can answer this quickly. Can anyone share successes they have had keeping perinatal youth engaged in medical care and taking meds? So any specific things you've done for youth to keep that retention going? And I know you have ideas out there. Julia, you do anything specific in your clinic to keep those perinatal youth coming back?
I'm going to put Rachel on because she can speak to this.
I think to say any intervention that I have done that makes them take their medicine would be difficult to say that I had any influence really on them doing that on a daily basis. But just being consistent. Before me, I started in 2003. Before I was a social worker in this clinic, every 2 years, burnout rate was pretty high. Being a consistent person and making them know that even when we have a time they miss their appointment or they don't take a medicine, that's not going to make me have any judgment on them. I think just being there for them, and having my phone line or my email available to them is the only thing I can do. I can encourage them in all different ways, but it's really the youth. They have to do it every day, and then they're home having support is not always easy. So just having a consistent person in their life is the only thing I can say that I can do.
And I think the word you used, non-judgmental, I think is really important. I think they don't want to be judged anymore, and I think that's really important that you portray that type of concern. Okay, anyone else before we close? Okay, Michael, anything to share with us?
Well, yes, in fact. Thank you so much, everyone, for participating in today's call. This is the most full whiteboard I've ever had. We have 4 pages total. So what I'm going to be doing is taking the chat transcript and your questions that and comments you've included in the chat, and I'm going to be blending it together with this whiteboard content. Everyone who's on today's call will receive an email early next week that includes a link to the recording, the chat transcript, we're hopeful that some of this information will be useful to you as you try to continue thinking about this in your own home sites. And I'm hopeful that you also made some new friends and contacts on today's call so that you have someone else that you feel confident reaching out to and asking your own questions or sharing some of your challenges or even successes when you have them. So, very, 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 very warm, thankful, sentiments to Jane and to Julia and to Rachel for sharing your perspective with us on today's call. But also a special thank you to all of you who've called in. Lots of great sharing from folks, around the country. We heard quite a bit from Missouri and from Oakland and from Tennessee and many other places too. And we wouldn't be able to make programs like this happen without you. So thank you very much. And I think that's it. Jane, Julia, Rachel, anything else you want to say?
It's the same. Thank you, everyone, for participating. I think it's been a wonderful discussion.
Thank you.
All right.
Thank you.
Bye, everyone. Thanks, and have a wonderful day.
Thanks, Michael.